Well, welcome everyone. Thank you for joining us today. I am here today with my colleague, Dr. Calfee. We are two of the hand and upper extremity surgeons in the orthopedic department at Washington University, and we're coming together today to discuss thumb arthritis. We both treat this. I also have an interest in pediatric and spasticity, upper extremity conditions, but I'll let Ryan introduce himself. I'm Lindley Wall.
Well, thanks, Lindley. So yes, I'm Ryan Calfee, one of Lindley's partners at work, who does hand and upper extremity surgery. And I really enjoy seeing a wide variety of patients with hand conditions, kind of all ages and all comers, things that are related to arthritis and aging and things that happen traumatically and unfortunately, but happy to see and try to help folks.
Yeah. So our focus today is actually to talk about, if you can kind of see my hand, is the base of the thumb. So this area here, which can be very painful for a lot of people. So we're going to talk about arthritis at that joint and pain and kind of how it presents and how we treat it. So Ryan, do you want to kind of give people a summary of sort of what you see in a patient and when they show up and what they complain of?
Sure. So lots of folks are going to get this thumb arthritis. And I guess maybe we should say from the beginning, when we say thumb arthritis, we mean osteoarthritis, just kind of the normal wear and tear that happens with aging, somewhat related to your genetics, and exceedingly common, especially among women. But it's not the rheumatoid arthritis or autoimmune issues. So people come in and they typically say they're having a lot of pain and discomfort, sometimes like a toothache all the time, other times more of a sharp pain with doing activities. And just as Lily said, people will come in and tell me it hurts anywhere from the base of the palm all the way around to the back of the thumb. And I feel like I get a lot of folks that will tell me specifically things like, I can't open a tight door or a jar or Ziploc bags. They feel like they just don't have any grip strength, which is awesome.
Turning the key in their car. Yeah.
Yes, the key of the car is a good one. What other ones do you hear, Lindley?
You know, I think holding the phone, texting, which, everyone, I don't think it causes it, which, everyone wants to blame that on different arthritis, but it does. I think it just can aggravate. But yeah, it's a lot of the squeezing, the pinching, sometimes twisting, yard work where you're pulling weeds. That can be really painful. Yeah. I think we see that there's a lot of things that can make the thumb hurt and isn't all arthritis. So I think that's sometimes for me when patients come in, really defining and ensuring that it is the arthritis that they have is kind of making sure it's not something else. And I think, that's definitely our job as a hand surgeon is to identify exactly the pain generator. And so while the thumb can be painful, it can be arthritis coming from this joint, which we want to talk about. It also can come from other places at this joint here or down at the wrist. What are the couple common things you see that sometimes can mislead you? What do you think?
Sure. So I think, first of all, I think a lot of people show up with any hand pain being carpal tunnel.
Yes.
And we have to reassure them this is not carpal tunnel. This is thumb pain. This is not the numbness in the hand. But the things that can be a bit confusing, like you mentioned, this other joint up here, it can have arthritis, or you can get something called a trigger thumb, where the tendon is actually catching and causing pain that can radiate down the hand. And then there's a common tendonitis that you can see just on the side of the wrist, just slightly back from that thumb joint. And that's something that can also cause sharp pain, and we see it a lot with young mothers or people lifting either new pets or new children or grandchildren that can irritate that. So we're always looking kind of for the surrounding joints and the other arthritises and tendinitises that can get you. Do you also similarly people that will come in with this pain after some sort of trauma or injury?
Yeah, I think that sometimes a minor trauma or even a bigger trauma can sort of start the pain that they may have always had some arthritis there, but then some trauma will kind of start it and kick it off and just flare it up. They'll say they haven't ever had pain, but then on exam, absolutely what Dr. Calfee was saying is that there's pain here. That's not the arthritis pain, but down at the base, like right there, even if you've fallen on it and it can incite it, and you may have some underlying arthritis. And one of my mentors always said, everyone has their first day of arthritis. And so sometimes there can be one thing that just kicks it off. So I also wanted to support what you said. I didn't want anyone to think that you were pushing this as a condition we see mainly in women, but there is a component of estrogen. We know from some of the basic science research that says that it makes, joints are a little bit looser. So as women, we definitely are more inclined to get this arthritis. And so the joint is just a little bit looser. There's more rubbing of that cartilage. So it is true. And so it's just a fact. And that's how we take care of it. So. Yeah.
Exactly. I think you're exactly right. And I think your comment about the trauma irritating it is exactly right. I think I've told a lot of patients that, the joint probably had a little wear and tear in it. And maybe that bit of trauma was like kicking a hornet's nest. Now it's angry and upset and, it's letting them know about it for sure.
What do you think? Do you always get X-rays? Do you like using X-rays for this? What are your thoughts?
That's a good question. And patients have that question. I don't always. And I hope people aren't put off when we see them in the office if we don't say they need X-rays. But, this is a diagnosis that we can usually recognize based on the description of the symptoms, based on actually doing a careful physical exam, where we're actually, very carefully feeling the joint edges as well as the surrounding tendons and soft tissues. And if we can make that diagnosis and we know the joint that hurts, I think the primary reason that I don't always do X-rays is that it doesn't matter if we look at an X-ray and we say, oh, you have mild arthritis or severe arthritis. We know the joint hurts, and we're always going to start with more conservative, less invasive treatment to begin with, even if something looked bad on an X-ray. So for me, that's why I don't always get X-rays right away. How about yourself?
I think I feel the same way. We're pretty lucky because we have a easy way to get X-rays in the office that aren't the big, huge official X-ray machine where we can do sort of quick X-rays. And I think I like getting it because it helps me talk to patients and kind of show them the joint. But I absolutely agree with you. I don't do it on everyone. And it has to do more with symptoms, right? I'm not treating the X-ray. And so for this, it's primarily a symptom issue. And it's very common, it's the most common place in the hand to get arthritis. So it doesn't surprise me when someone has pain there. But you're right, I treat the symptoms. I always start conservatively. So on that note, how do you start? Someone comes in their first time, they have pain. What do you do?
Well, I think first we talk about it, right? Just like you said, I think it's understanding that this is really part of life for men and women. It's for more women than men, but it really is. It's part of life. It's part of aging. And so that part of it's normal. But by the same token, we want to keep people functioning and doing what they're going to do in life. Because at least it's my belief that, what they want to do in pursuing their activities isn't going to damage this more. I think whatever it's going to do, the body and the genetics are going to do. So I want people active and doing their thing. So we start with anything we can to reduce inflammation. So the primary ways for me to reduce the inflammation and irritation of that joint are either to do some small bracing or supports, whether they're soft or rigid, or potentially doing some anti-inflammatory medications orally. We've got various over-the-counter or prescription versions of those things, or even topical medicines. So I really focus everything in the beginning on reducing irritation, whether that's medicine or mechanically with bracing and splinting. Do you have a favorite way to start?
Yeah, I push bracing. I think anti-inflammatories are very helpful. Usually people have their own opinion about what they like and what works, and so I let them pick. I definitely like bracing. I like the stiffer braces, and you may do the same as I, but I like it when the therapists kind of make a custom brace, because when they're stiff, usually you have to kind of mold them so they fit nicely. So our OTs are wonderful. They make them for them, and then they can be adjusted if needed. But I think they provide a lot of support, and we're primarily just trying to support that joint so it's not moving around. It gets less pressure. And I tell people they don't have to wear it all the time. It's a tool. It's something that if they get some inflammation and they're using it, that they wear the brace in times where it's necessary. So if they get a flare up one day, they put it on. They go work in the yard, they put it on, something like that. And then I also think therapy can be helpful in the sense that they can provide suggestions of how to modify activities. Sometimes some strengthening, a little bit less with regards to like working on motion and stretching, but kind of how to open a door differently, or if there are any tools to help calm the joint down. I mean, it's all the same philosophy of just calming things down. So, and I will tell people, wear the brace as long as it's helpful. And then it'll potentially get to the point where it's not helpful enough. So, yeah.
And like you said, everyone's response is different to bracing, and everybody's lifestyle is different. So I've got some people that love, like you said, they put it on when things are acting up, or maybe they just wear it at night. Other people love wearing it during certain activities that it kind of gives them that support. I've certainly had patients who will make an appointment with me every 2 years because their brace is just basically disintegrated at that point, and they're like, I need new ones.
And people tell you they'll never wear a brace.
Yep, and other people are like, I'm not doing it, and I'm never going to make somebody do it. Right. It's all about, I think, in the office, a lot of this is about educating people about kind of what's going on with their body, and then giving them options. And as long as the options are reasonable, I am happy to pursue, what they would like. But I do think, and I think your point about the therapist offering more than just the brace, I mean, they really do. They mold it nicely, they get it fitting, and then they give those suggestions for life. We don't want to stop doing certain activity. Well, then how can we do it and have less pain? Or how can we modify things slightly, whether it's the positioning in yoga or the tennis racket, or how do you fix the golf club to make it a little bit less sore? They offer a lot. So I agree with you.
Yeah. I think this is also the time when the braces aren't working, anti-inflammatories aren't enough. This is, everyone thinks orthopedic surgeons always want to inject people, but this is one of those times where cortisone injections are a fantastic tool. And once the brace isn't enough, or if someone's inflamed enough, this is where I really like to use cortisone shots. I'm assuming that you think similarly, but take me through your thoughts on what you tell people about injections.
Sure. So I tell people that if they've been going along stable for a while and something happens, or they do more activity and things flare up, that the injection will do marvelous for them usually. For the folks that just have the ongoing pain from down, so that's not going to grow back. But if I can do basically, say, 2 or 3 injections in a year and keep somebody functioning really well, and keep them out of the operating room and not having to do something invasive, I'm happy to do that as long as they are getting relief. Because I do think it's a great tool to keep people going and not necessarily have people taking pills every day.
Yeah. And I think there are people, we know there are people out there that arthritis will burn out over time. Yes. I don't know who they are, but there are some people who will never need a surgery for this. So
you're right.
That's why I like injections. It may help us help them get through it. So
get past this portion of life when that joint is painful. Because yes, when people ask me, so they say, well, what in the world is going to happen in 5 years? I hurt this much. I'm here with you today, but I'm going to be awful. I won't be able to use my hand. And I tell them that's not true, because if we do keep taking X-rays, the X-rays will show worsening arthritis over time. That's what happens to everybody. But clinically, like you said, Dr. Wall, I mean, not everybody hurts more. And we'll see a lot of folks who will say, my thumb used to hurt years ago, and they've got clearly very bad arthritis looking at it, and yet it's not the problem anymore. So something happens. The pain signals either burn out, or the joint gets a little stiffer and then it doesn't hurt anymore. But certainly this is not a guarantee that however you feel today will be worse in 5 years and worse than in 10.
Yeah, absolutely. But there is a point. I think I have a similar philosophy. I'll do injections as commonly as every 3 months. If we start getting to the point where injections aren't doing it, or they need them more frequently, I think that's a good point where I start talking about a surgical option. For the same reason, I want people to get back to their life and be able to use their hand without discomfort. And so I know we have 3 sort of general type procedures, all with a similar focus. But the idea being that, it's this joint here, you have your metacarpal bone and then your trapezium, and it's the joint between that's the pain. And so the surgeries for this are to get rid of that painful joint. And there's a couple different ways. I don't know if you want to take on one of those techniques and we can kind of talk about it.
Sure. So I guess the essence of all of them, though, we tell everybody, just like you said, you've got that metacarpal bone. The little bone below there is what's rubbing bone on bone per se. Right. So we go in and we take that little bone out. Well, then now you don't have any more bone rubbing on bone, and you've got a thumb that can move over space. And then I think most of us, most hand surgeons in the United States, feel like we want to do something to then support that thumb so it's not too loose. So we will go in and either use tendon from the body or use heavy suture of some sort to basically make some sort of support for the thumb.
Yeah. And you're talking about, you know, this bone not coming down or moving too much because we've taken its base away. Yeah.
Yes.
Do you have a favorite surgery?
Oh, I don't know if I have a favorite. You know, I think that the good news is regardless of anybody's favorite, these surgeries usually do really well. You know, I agree. Like everything in medicine, you know, pain is a bit complex and not every patient is going to have, you know, normal function restored. It's not going to make the entire hand 19 years old again. But the vast majority of people feel so much better. And I think that if you look at the number of people who have a surgery like this and then have to come back for another one for some reason, for some complication, it's so rare. And so I think that, you know, this is a really, really good surgery. Now, I suspect that your feelings are probably the same as mine, Dr. Wall, that you know, we don't jump to it though on the first visit because it's such a good surgery, but you know, the recovery can be a bit slow. So I'm curious, you know, what do you tell folks looking at this surgery in terms of what to expect?
Yeah, you know, I think that some of our techniques are changing a little bit, as you kind of insinuated, but I sort of kind of base it on what someone told me once about getting a total knee, which I think people are a little bit more comfortable with kind of that concept. It takes a while to recover. I say the same thing about this. You know, while it's a smaller incision and it's a smaller joint, there's a time period right after surgery where you're not really going to like us as surgeons. It's going to be sore. It's not going to feel good. And then as it heals over time, it starts feeling really good. And then you can use it. So I usually give people, it's going to be a few months before it feels like you're unrestricted and you're using it, gripping and strengthening. So it just takes a while. And if you can avoid that, you know, by doing injections and stuff, I think that's absolutely the way to go. But, you know, the one other thing you were talking about, you know, the goal is to get rid of that painful joint. You know, some people, we take that bone out, and then some people, I don't do it as much anymore, but fusing the joint. So where you make this bone heal to this bone. It's the same concept though, getting rid of the painful joint. You end up with a little bit less motion, but some people like that option, and some surgeons preferentially like that for, you know, different populations. But you know, I think it's a good surgery. I think we do it pretty commonly, you know, just this surgery in general, taking out the bone and suspending it in some way, classically using either a tendon from the wrist, a tendon from the thumb to do that suspension. I think one of the, you know, the neat thing is here we're doing a little bit more without the tendon and using some little anchors and a big thick piece of suture to try to hold the thumb up. And I've been pretty happy with that. I don't know if you are doing more of those, but I've kind of liked it. It gets people out of their post-operative dressing a little bit faster, and I don't cast them afterwards like I do for the other one. So
sure. Yeah, I think it's the same. You know, I think as the techniques have advanced a bit, that suture suspension, since you're using something artificial that's anchored immediately in the bone, you don't have to be quite as cautious early on in terms of waiting for a tendon graft to heal. And those folks have seemed very good early on in terms of they don't come back quite as sore, and they get going quicker. So I do like that technique, and it's been working well. I think that I've been trying to make the best judgment I can on each patient when you get into the OR based on sort of how the tissues are, the bone quality, because if we're using the suture, we need the bone to really hold. And so there may be some reasons that we choose one or another for certain patients. And I usually go into the operating room with both as options so that we're prepared for both, but knowing that we're going to do the very best we can for each person's thumb, specific to their anatomy. You did mention the fusion, and I apologize, I didn't mention that earlier.
Yeah, no.
I think that the operation, it's interesting. When you take away a joint's motion, you'd think it'd be a huge, huge loss. But in this case, it's actually really well tolerated. But I would preferentially offer that to people that either are doing very heavy manual work, whether that's at home doing tons of work with chainsaws and things, or doing manual labor, such as construction workers, sheet metal workers, people that are going to really put a lot of force on it because we think that'll offer a really stable post to pinch against. And then maybe the other group of people that I would think about that more would be the folks with a lot of sort of looseness in the joint, where we worry about things not being tight enough.
Yeah.
So we will consider that. But you're right, the usual treatment is more of the variation of taking the bone out.
Yeah, absolutely. You know, I think it's just a kind of a plug for what we do here. I think it's great because I think we don't jump on any new technique quickly. And I just hope people appreciate that. And we try to base our decisions, sort of our group specifically here at WashU, using some of the literature and also ourselves kind of very systematically looking at how patients do after surgery and looking at what their presentation before and then after, and trying to look very scientifically at our outcomes. And so we're doing that with sort of one of that newer technique with the suture, and I'm really excited to see what that shows. But you know, just sort of clinically, in my personal opinion, people are looking good, which is great. So, but I think also, as you said, this is a surgery in general that does well, which people should know. So, yeah.
I think that's a great point, Lily. I mean, I think that, you know, at least within our department here, I think that everybody is up to date with everything that's happening in terms of any advances on the topic. I can't think of anybody offering anything that's sort of not been a little bit tried and true, at least across the country. We're not experimenting in that way. And yet when we do adopt newer things that seem to already have a good track record, we are trying to rigorously look at this scientifically. And so, like you mentioned, you know, we're doing a study on this topic. The surgeons in our division really working collaboratively to really track our outcomes and find out if things are as good as we believe them to be, and if we can test it and show and document for the rest of the surgeons in the country, then I think it helps everybody get better care.
Yeah. Absolutely. You know, the one thing that patients ask me, I don't know if you get this question, but we've talked about sort of our approach, and I think it's probably common with our partners here, but also people ask about actual joint replacement, you know, putting in a piece of metal, so metal on metal to create a new joint, or using like a silicone implant, which is kind of like a spongier plastic implant. I have very strong opinions. I'm happy to, why don't you start, and maybe mine will seem more tempered.
Oh boy. So if you put me on the spot to potentially disagree with you a lot, I think those type of implants are definitely out there. Some groups have reported reasonably good outcomes with them, but in every study that's been done with those, the rates of complications have been fairly noticeable in terms of being more than I would like. And the chance of revision surgery for various reasons has always been higher than our standard treatment of taking the bone out and suspending it. So I have yet to recommend that to one of my patients. And I think it's going to take a lot more evolution in that field in terms of developing something that really works before I would do that. But yes, they are out there. But what are your strong feelings on the topic?
No, I think I completely agree with you. I think there's people who, I think with these implants, I don't use them myself. And there must be certain technical nuances that that certain people who either design them or do them very frequently probably have better success than what some of the literature proposes. So I don't typically recommend them or use them. So everyone kind of asks that, and it's just nice to kind of get it out there. And maybe one day that'd be great. One would be designed, but hopefully people will, you know, fix arthritis, or we could cure arthritis first, but we'll see.
Sure. So I guess that kind of leads into the one question I wanted to ask you, because I think I get this a lot in the office as well. Is about this osteoarthritis, and well, is there a preventative thing that we can do? I mean, you see the ads on the TV and things with all these medicines and such that are used for various arthritises, but is there something preventative to do for osteoarthritis in the thumb?
You know, I don't know if there is. I think there's different medications, injections that can help, but they don't help everyone. So I don't ever push them. Injections like the rooster comb injection, which a lot of people get in the knee, you know, it works in some people in the thumb. I haven't done that because it's not as well, I don't know, accepted, or if people don't do it as frequently. I typically stick with the cortisone to help with the symptoms. I think other people use PRP. I haven't done that either. I haven't seen the literature to show that it's dramatically better or slows arthritis. So I don't know anything that necessarily slows it. You know, glucosamine is helpful for symptoms. I don't think there's any good literature to show that it's changing the natural history. So it'd be great if you knew of something to change it.
I don't, and I would have loved it if you had the answer, because if you did, I was going to say that as my new answer. But
yeah.
You know, I think that, unfortunately, for as common as it is, you know, it's kind of like, is there a cure or a preventative thing for aging? You know, there's not. Our joints are going to age. The cartilage gets less good. And so for some people, it happens very, very early. It's not quite like you have to be older. I mean, this can happen to a range of people, but it is part of that process. And at least so far, the medicines that change arthritis, like actually stop it from happening, those are things that fit into that rheumatoid category or autoimmune diseases. Whereas for osteoarthritis, maybe this will be different 10 years from now, 20 years from now, 30 years from now. But as of right now, I'm not aware of anything that's going to really change the wear and tear on that joint or what's going to happen based on that. So again, we get back to treat the symptoms and keep living life and hopefully doing the things you love. And, you know.
Yeah. And your target, I mean, and that both goes for like locally applied injections and also oral medication. There's nothing we know. So, but one day, I think someone.
One day, I think there's a lot of people smarter than us working on it.
Yeah. Absolutely.
We're not there yet. Hopefully one day.
Yeah. I think we covered everything, which is great. We appreciate everyone joining us today, and we're happy to see you for your thumb pain or anything else. So thank you.
Yeah, thank you so much.